Hi, good morning. I think we'll get started here. Thank you all for coming. Thank you for taking time to learn about a topic that interests me a lot: shoulder arthritis, chronic shoulder pain, and rotator cuff injuries. If you have any questions along the way, please feel free to stop me at any time. The shoulder is the third most painful joint in the body, behind the knee and the low back. Symptoms of shoulder pain include chronic pain, compromised function within the shoulder, and mostly a combination of these, both pain and difficulty with motion. This often results in a lot of difficulty with sleeping and with activities, especially overhead. Just a brief look at the anatomy of the shoulder. Here we have the ball and the socket. The ball is really the top of the humerus, which is the arm, the upper arm bone. And then we have the shoulder blade, the scapula here, which is really in the back. The glenoid here, which is the socket, articulates with the humeral head here. In addition, in the shoulder, we have the clavicle, which is the collarbone, and a piece of the acromion, which is part of the scapula, the shoulder blade. There are a variety of causes of shoulder pain. We know shoulder pain can be caused by rotator cuff tears, but by arthritis in the shoulder, by fractures of the shoulder, which are very common as people get older, and by shoulder dislocations, which can happen both in people that are very young and very old. So let's talk about the shoulder itself. This is a schematic of the shoulder. We see again the scapula here, the shoulder blade. We see the arm here, and we see these muscles that turn into tendons as they come down to the humerus, the arm here. The rotator cuff is a group of 4 muscles, which we'll go over in a second. We see that tears commonly happen at the insertion of the humeral head here. So this muscle here would be called the supraspinatus. Its insertion here on the humeral head, you can see that it's torn off and pulled back a little bit, as compared to this here where it's attached nicely. Arthritis is a very common cause of shoulder pain. Here we can see a normal schematic of a normal shoulder. So you can see here that the head is nice and round. You can see the socket, the glenoid, is a nice curvature to it. But here, if we look at this next image, we can see that here really that curvature is a little bit flattened. We can also see that there's some redness there, which intraoperatively looks like inflammation, a lack of cartilage, so a lack of a smooth surface around it. And you can imagine that the space here is now smaller than it was in the last image. And so really the space between the bones is much smaller. So much like in a knee or in a hip with arthritis, the space is really gone and it's rubbing bone on bone, which causes a lot of pain with motion. Fractures of the shoulder are very common. So fractures of the shoulders can be in a couple different places. Here we see a line. This would be considered the humeral neck. There can be fractures in this region. There can be fractures up here in what's called the greater tuberosity. There can be fractures here in what's called the lesser tuberosity. There can be fractures through the head. But most commonly, you'll find that people have fractures in multiple locations in the shoulder. So with osteoporosis and older age, the shoulder bones become weaker, and so you may have a fracture line here and here, or maybe here and here and here. And so we'll talk about treatment options. Luckily, most people with shoulder fractures do really well with a sling and some therapy and time, but some people have bad fractures that really require much more than that, and so we'll talk about that as we go forward. Shoulder dislocations are a common problem. This often happens in patients that are young, say in their teens, 20s, 30s. It can happen to someone in their 30s and 40s from some sort of traumatic injury, and it can happen in someone older from usually a small fall or some sort of traumatic injury of that sort. And shoulder dislocations can cause a variety of difficult issues in that shoulder dislocations can go either back, so back this way, or forward this way. They can come down this way. And that can cause tears in the rotator cuff. That could cause trouble with the labrum, which is a cartilage or a bumper around the shoulder, which allows the shoulder to move with stability. And it can also cause problems with the cartilage itself in the shoulder. A shearing force from a dislocation may disrupt the cartilage of the shoulder that over time may then degrade to create some forms of arthritis. So let's talk about the anatomy of the shoulder before you go further. The shoulder really can be thought of as a golf ball on a tee. I think that's a very good analogy for this. The shoulder joint itself is inherently unstable, so we can see here, really there's a very small tee and a very large ball. So how does this actually stay together? We know that there are a lot of ligaments, tendons around the shoulder that allow for this. We in addition know that the bony structure has a concavity to it, so the bones here are curved and the ball is curved, so it generally sits in that groove. We know that the rotator cuff is the most important dynamic stabilizer of the shoulder, meaning this is the most important part of keeping the shoulder joint in the correct motion and the correct movement during motion. There are a couple of different rotator cuff muscles. Here we can see the back of the shoulders. So this is, if we're looking at the back, at someone's back, the front would be over here. And we can see here is one muscle called the supraspinatus, and there are others here, the infraspinatus and teres minor. 3 rotator cuff muscles. These muscles help with rotation of the arm as well as elevation of the arm. If you look at it from the front, you can see also there's a muscle here called the subscapularis. This is different than the other rotator cuff muscles in that it's at the front of the shoulder. It helps mainly with internal rotation of the shoulder and is less commonly torn in, say, a shoulder dislocation or rotator cuff tears. So let's talk about some causes of shoulder pain and compromised function. I'd like to group these two together, rotator cuff tears and shoulder dislocations. The reason for that is shoulder dislocations in patients over the age of 40 have a high propensity to cause rotator cuff tears, and so it makes sense to talk about them together. In patients that are younger, oftentimes shoulder dislocations lead to what's called instability, meaning that the shoulder may feel like it's going to re-dislocate with certain motions, especially with the arm overhead or externally rotated, such as this. So the rotator cuff, let's talk about that a little bit more. The rotator cuff is, as we talked about, a group of tendons. Rotator cuff disease is really a grab-all basket of topic which talks about rotator cuff tendinitis, rotator cuff tears, and just rotator cuff inflammation. It really is the most common cause of shoulder pain. We talked about the rotator cuff in that it helps lift the arm forward, it helps externally rotate the arm, it helps internally rotate the arm. We know that tendinitis is an inflammation of the rotator cuff. Tendinitis can be inflammation of any tendon in the body, specifically here in the rotator cuff. Tendinitis is not a full tear, it would just be some irritation. But you can also have a lot of weakness and discomfort from just tendinitis itself. A tear of the rotator cuff can cause a significant amount of symptoms, and it can be what's called a partial tear or a full thickness tear. So you may have had an MRI, and the MRI may say partial thickness tear of the rotator cuff. And so then that's sort of a gray area. What do you do with that? A lot of people will try therapy, maybe some injections, some medications. Some people will get better, some people won't. And so we'll talk about treatment options for rotator cuff tendinitis, partial rotator cuff tears, and full thickness rotator cuff tears. We talked about shoulder dislocations, and so we know that for about 30% of people over the age of 40, there's a high chance of rotator cuff tear with a shoulder dislocation. It's a traumatic injury. The shoulder joint is pulled either forward or backwards or down, and so you can imagine that the tendons just can't hold on. So in the case of rotator cuff tendinitis, almost all patients respond to non-operative treatment, meaning that with the right type of anti-inflammatory medicine, with the right type of physical therapy, with maybe an injection of corticosteroid into the shoulder itself, and some time, maybe around a 3 to 6 month period of this, people get better. There's a group of people that don't, that may actually have what's more than what's seen on the MRI, and so they may have a partial thickness rotator cuff tear. The majority of those patients get better with just non-operative treatment alone as well. The category that really goes on to surgical treatment is someone that has a traumatic or a full thickness rotator cuff tear. So please.
If you've had a full rotator cuff tear and you haven't had it repaired, is it amenable to physical therapy? I mean, I tore my rotator cuffs in 1983. I didn't have insurance, and it's just been a chronic problem.
Yeah, so that's actually a very interesting and nuanced question. So you can, it depends, rotator cuff tears depend on age also. So patients that are, say, in their 30s and 40s with rotator cuff tears tend to not do very well with non-operative treatment with physical therapy. As we get older, there's about a 50% rate or 60% rate of rotator cuff tears in people that are asymptomatic that are over the age of 60. So if you were to MRI everyone in this room and say everyone in this room was over the age of 60, about half of the people in this room would have a rotator cuff tear and they didn't even know about. And so for that case, a lot of people do really well with rotator cuff tears that are over the age of 60 with just treatment through therapy, medications, and injections.
Very severe. I mean, it was really painful. I couldn't sleep.
Yeah.
If you have a rotator cuff tear and don't have it repaired, won't it continue to get worse?
That is true. So rotator cuff tears do progress over time if you have a full thickness tear, and it can get to a point where the tear is much larger than it was when you initially found it. And so oftentimes the best treatment is to catch it early and to repair it at that point in time. There are people that, because we have other muscles in the shoulder, such as the deltoid, the muscles in the back, the muscles in the front, they compensate very well for rotator cuff tear. And so that's why you don't always have to go towards surgery, even if you have a large rotator cuff tear. So if you had a large rotator cuff tear that was traumatic and wanted to do or continue certain activities that you were unable to do after trying a brief period of treatment such as medication and therapy, arthroscopic rotator cuff repair would really be the best option. So arthroscopic surgery, meaning there are 3 or 4 small incisions about 1 inch long each, utilizing a camera to look inside, utilizing cannulas, so basically shuttling portals to put suture and other things to heal the repair. And so we'll talk about a case example of this as we go forward. This is an MRI of a rotator cuff. So this is an image of the shoulder if you were looking from the front to the back. So the shoulder, the outside would be here, the chest would be somewhere here. This is the ball here, the socket would be right here, and this is the arm going down here. And we can see this black area here. This is actually the rotator cuff muscle. And you can watch it as it comes down here, and it inserts actually on the humeral head. And that's an intact rotator cuff, meaning that the rotator cuff is in its right position. On this image here, you can see the same thing, but here you can see a big white space. And so really the rotator cuff tendon ends here when it should end here, and so it's retracted back maybe 1 centimeter or 2. And we can see, if we pull that box there, this is really the distance in which it's retracted. And so that would be considered a full thickness rotator cuff tear, something that if you had and wanted to proceed with surgery would do very well with surgical fixation. We know that about 400,000 rotator cuff repairs are done every year in the US. We know that this is a very, very common surgery. It's an outpatient surgery. We know that they've evolved over time. So 20, 30 years ago, people were having rotator cuff repairs through an open incision, maybe this long in the front of the shoulder to repair the rotator cuff. And now they're being done through 4, maybe 1 inch incisions in the shoulder. Patients feel a lot better about that. This is how it would be done. So this is a rotator cuff. So this is if you were to look down on your shoulder and say this was the outside of the shoulder and this is going towards the neck here. This is the rotator cuff tendon in line. And here we can see that some sutures are placed in the tendon, and then they're tied into anchors at the point where they should insert on the bone. And they're put together oftentimes in a cross configuration like this to hold the tendon down on the footprint very nicely. And so that really allows for you, with that sort of solid fixation, to start doing physical therapy right away. So most of my patients, and I think other people's patients, will start doing physical therapy within a few days of a rotator cuff repair, and hopefully have full passive range of motion around 6 weeks and active full motion about 3 months.
What's the time period that you have to be able to repair it with surgery before it's too late?
So that depends on the amount. So the best way would be to have a new MRI, and then we'd know how much retraction you have, and so we'd be able to say, okay, this is still repairable, or maybe this has been too far gone to repair. But there are other options for that if that's the case. Well, there are other options, but it wouldn't be rotator cuff repair. It may be shoulder replacement of some sort.
I'll deal with it.
Okay, sure.
Was, in this case, is there ever biological adhesion of the tendon back to the bone, or is it strictly these sutures?
So that's actually a great question. The purpose of this is to allow for biological healing of the tendon back to the bone. So the goal of this is, basically we know that this area here is what's called the rotator cuff footprint, meaning that the tendon has an area here of a couple millimeters where it attaches to the bone. And so by pushing the suture down onto the bone, we create a surface area for it to re-heal. It takes about 12 weeks for tendons to heal back to bone anywhere in the body. And so we can't speed that process up, which is why I bring up the 3 months of rehabilitation afterwards. But if we do it right and with the right amount of tension, it will heal back to its normal position. So arthroscopic rotator cuff repair is done as an outpatient. It's about a 2 or 3 hour procedure. You go home the same day. You wear a sling for generally about 3 weeks. It's sometimes variable. Some people wear a sling for much less time. Some people a little longer if it's a very tight repair. And physical therapy is done about 2 or 3 times a week for about 3 months or so.